Fibular head.
That's right here.
Common peroneal nerve.
It runs laterally, it comes down in branches.
Peroneus longus muscle.
That comes down and inserts on the plantar aspect on the first metatarsal, or the first cuneiform.
Peroneus brevis muscle.
That's distally and comes down and attaches to the base of the fifth metatarsal.
Fibular shaft.
That you can palpate all the way down the bone.
Lateral malleolus.
It's right here.
Peroneal tubercle.
That is right in here.
Calcaneofibular ligament.
Goes from the fibula to calcaneus right in here.
Anterior talofibular ligament.
That goes from the fibula to the talus right in here.
Posterior talofibular ligament.
That goes from the fibula, wraps around, and connects to the talus on the posterior side.
Anterior and posterior tibiofibular ligaments.
The anterior tibiofibular ligament is here. The posterior tibiofibular ligament is all around the back.
Peroneus tertius.
The peroneus tertius comes here, goes through here, and attaches to the shaft of the fifth metatarsal.
Tibial tuberosity.
That's where the patella tendon attaches right in here.
Gerdy's tubercle.
It's laterally and is where the IT band attaches.
Anterior tibialis muscle.
The muscle is right in here.
In case I didn't say anterior tibial shaft, do that one.
The anterior tibial shaft is right here. It's the shin bone.
Extensor hallucis longus.
Can you bring your toes up? That goes right through here.
Extensor digitorum longus tendon.
That runs through here, comes up right in here.
Extensor retinaculum.
The superior extensor retinaculum is by the tibiofibular ligament, and the inferior extensor retinaculum is on the medial midfoot.
Dome of talus.
That is right in here.
Sinus tarsi.
It's a little depression or groove right in here.
Medial malleolus.
It's right here.
Deltoid ligament.
Makes a triangle right in through here.
Sustentaculum tali.
It's a little shelf, which is right there.
Tibialis posterior muscle.
That comes here and goes deep to the gastrosoleus complex.
Flexor digitorum longus muscle.
That comes down and attaches to toes 2 through 5.
Flexor hallucis longus muscle.
That comes down and attaches to the posterior side of the first metatarsal.
Gastrocnemius soleus complex.
That's back in here.
Achilles tendon.
It's a tendon back here.
Subcutaneous calcaneal bursa.
That is in between the skin and the Achilles tendon.
Subtendinosus calcaneal bursa.
That is in between the Achilles tendon and the calcaneus,
Calcaneus.
which is right here. So now I'm going to move on to active range of motion. So I'm going to have my patient off the table. I am going to do, I'm going to have them bring their feet up towards the sky for dorsal flexion and down like they're pushing on a gas pedal for plantar flexion. Push their toes towards the middle for inversion, and push their toes that way for eversion. So now that I have that, I'm going to do my goniometry. So the stationary arm will be here, and this will line up with the lateral malleolus, foot in like a neutral position. So the fifth metatarsal is where I will be going. Good. So the first one I'm going to do is plantar flexion, so I'm going to have them push on the gas pedal. So it is about 45 degrees, which normal is 50 for plantar flexion. So now I'm going to do dorsal flexion, so I'm going to have you back in a neutral position. Now I will have you bring your foot up to the sky. So, look about that. That's about like 22. The normal is 20. So now I'm going to have it a little bit differently. So the joint line is right in here. tibia. The movement arm is on the second metatarsal. So I'm gonna have you do inversion first. I'm gonna have you move all the way that way. Okay. So that looks to be about 17, which the normal range is 15. No, it's 20. Normal range is 20. So now I'm going to do the same thing, but I'm going to do eversion. So I'm going to have you move your foot that way. That is about 5 degrees, which the normal is 5 degrees. So now I am going to do passive range of motion. So I'm going to have my patient all the way lying back, all the way on their back, so they're going to be supine. So for passive, I'm going to do it for them. So I'm going to dorsal flex, which they should have a firm end feel. Got a plantar flex, that should also be a firm end feel. Inversion should be a firm end feel. Eversion should be a firm end feel. So now I'm going to do my second dorsal flexion. So I'm going to have their heel off the end of the table, knee flexed. I'm going to bring that up for them, which should also have a firm end feel. So now I will do manual muscle tests. So I'm going to have them off the table with their knees extended. Yeah. Knees extended. So manual muscle testing, I'm going to hold here. I'm going to have you try and bring your feet up towards the sky. That should be 5 out of 5. I'm going to have you try and push down the glass pedal for plantar flexion. The other one was dorsal flexion. That should be 5 out of 5. Push towards the midline for inversion, 5 out of 5. Push towards the outside for eversion, which should also be 5 out of 5. I have the patient with their legs off the table for my second plantar flexion. So I'm gonna hold here. I'm gonna have you press down against my foot like you're on the gas pedal. That would be 5 out of 5. And for all of these tests that I'm doing, I would compare bilaterally to see if there's any differences. So now I'm gonna move on to my special test. So the first one I'm gonna do is my anterior drawer. So I'm gonna be holding here. I'm gonna press upwards. If there's any clunking or pain with this, that could indicate that the talus is shifting and is indicating a tear of the ATFL or a sprain of the ATFL. Next one I'm going to do is Kliger's. So I am going to hyper dorsal flex, evert, and externally rotate foot. If there's pain or problems with that, that can indicate a syndesmosis sprain or syndesmosis tear. The next one that I'm going to do is POTS compression. So I'm going to squeeze along the tibia and fibula, and if there's pain along the shaft, that could indicate a gross fracture. And if there's pain towards the bottom, that could indicate problems with the syndesmosis. The next one that I'm going to do while I'm still here is I'm going to do the bump test. So they're going to be in dorsal flexion. I'm going to hit the calcaneus. And if there's pain with that, that can indicate a stress fracture of the calcaneus, talus, tibia, or fibula. Now I'm going to do my Taylor tilts. So I'm going to do inversion. So no, I'm going to do inversion. So if there's extreme lateral gapping, that could indicate a problem with the CFL. And I'm going to do Taylor tilt eversion. So if there is extreme medial gapping or pain, that can indicate problems with the deltoid ligament. Now I'm going to do Homan's sign, which will have you dorsal flex while I extend the leg. If there's pain with that, that could indicate a deep vein thrombosis. And now I'm going to do Thompson's test. I'm going to have my patient lie prone. And I would squeeze up in the gastroc and their foot should plantar flex, but if it doesn't, that could indicate an Achilles tendon rupture. Okay, now I'm going to move on to neurovascular. So I'm going to look for my pulses. I'm going to look for my dorsal pedis pulse, which is in here. Okay, there it is, and then my posterior tib pulse. Which is right in here. Now I'm going to move on to my dermatomes, myotomes, and reflex testing. So to test for the L4, the dermatome would be right in here. So I'd ask the patient to close their eyes and ask them if this was sharp or dull, sharp or dull. The dermatome for L5 is in between the web space, so I'd have them close their eyes, ask them if it's sharp or dull, sharp or dull. Then for S1, the dermatome would be over here, peroneal side. I would ask them to keep their eyes closed, sharp or dull, see if they can differentiate. And S2 dermatome would be back on the plantar surface of the foot, the heel. I'd have them ask if it was sharp or dull with their eyes closed, and see if they could tell a difference. If they couldn't, then that could indicate problems with the nerves. The myotomes for this, for L4, that would be ankle dorsiflexion, so I'd have them bring their toes up towards the ceiling. For L5, that would be great toe extension, so I'd have you bring your toe up towards the sky. For S1, the myotome would be ankle plantar flexion, so I'd have you push down like you're on a gas pedal. And for S2 myotome, I'd have them bring their heel towards their butt for knee flexion. And then I'd check their reflexes. So for L4 and L5, both, that would be the patella tendon. So that would be L4, and then L5. And then for S1 and S2, it's the Achilles tendon reflex. So it'd be back in here. And then for all of the things that I've done so far, I'd compare bilaterally. So for this, if there's a problem with one leg not firing, it would be for an upper motor neuron lesion. If both legs didn't fire, it'd be a lower motor neuron lesion.